Now we're going to move on to our last segment of our forum. And this is focused on hospital-specific or key driver-specific efforts that are happening. And in particular, we'll be focusing on Lutheran Medical Center. So to introduce the speakers for this section, I will introduce Colleen Wheeler, who is one of our CHoSEN steering committee members and leaders. Colleen is an advanced practice provider in the neonatal intensive care unit at Lutheran Medical Center. And she also is our Eat, Sleep, Console expert in our state. For those of you from sites who are participating in CHoSEN Quick and Eat, Sleep, Console, you know Colleen quite well. She has led all of the workshops for CHoSEN Quick related to ESC. And I will embarrass her a little bit because I'm going to chat in this link from the local Denver CBS News when Colleen did an interview with them. And so after you're done with the forum, you can take a look. But I'm very thankful to Colleen for all that she has done. And so I'll let her take over and introduce our speakers.
Thank you, Susan, and thanks for sharing that link. That's been a while now since we did that, but anyway, so it's my pleasure to introduce these two key people out at Lutheran Medical Center and within the SDL Health or Intermountain healthcare system now. So first, we're going to hear from Amy Dempsey. She's been the clinical practice specialist at Lutheran Medical Center for the past 18 years, where she's focused on staff development and quality improvement. She's published several articles and presented multiple posters on topics related to the improvement of maternal child health. And she currently serves on 2 steering committees for the Colorado Perinatal Care Quality Collaborative and represents the state of Colorado on the AWHONN AIM Council. She has been invaluable in her role in the development and implementation of the Colorado SUD AIM Maternal Mental Health Project within the SDL Health system. We certainly would not be as far as we are down that road without her expertise. And then after her, there's Michelle Deuto, and she started her career as a new grad RN on the labor and delivery unit at Lutheran Medical Center back in January of 2002. She obtained her inpatient obstetrics RNC in 2007. And through a grant opportunity, Michelle began the Recovery Nurse Advocate Program in 2016. Her role has been an invaluable resource to not only the women receiving care at Lutheran, but the surrounding community as well. So we'll start with Amy.
Hi, can you hear me?
Yes.
Okay, great. So I just would like to add that Michelle was a luminary for Nightingale this weekend. Need to add that to her introduction. We can go ahead and advance to the next slide. I just wanted to give an overview of what it means to take a system through this work. So my role has been to facilitate 8 sites. I just wanted to give a little bit of background. SDL Health has 8 hospitals. 4 of them are in the Denver metro region. 1 is in Grand Junction and 3 are in Montana. And we were allowed to join the Colorado Collaborative, even with our Montana sites, so that we were all headed in the same direction. And since the inception of this committee, we have merged with Intermountain Health. So more to come on that. I cannot say that I'm going to lead the entire Intermountain region on this or health on this journey, but for the 8 sites, I'm happy to facilitate this. So the next slides just talk a little bit about who we are. So we'll flip through those quickly, but I wanted to just point out that we have representation from every single hospital, including system. And we meet on the 4th Friday of every month at noon, and we have amazing attendance, a lot of collaboration and commitment to this project. Many of our hospitals were already part of the CHoSEN collaborative, so to expand this work and focus on the maternal side of this was a fairly intuitive and easy transition. So the next slides talk about who we are. We can skip that one in the interest of time and just look at, these are the 4 Denver-based hospitals. Obviously, St. Joe's is our largest and has the highest delivery volume. They're about a third of our system. And then we have Lutheran and Good Samaritan. All three of those hospitals see Kaiser patients. Lutheran is by far the highest in terms of Medicaid volume. All of our 8 hospitals are predominantly white. And Platte Valley is our smallest of the 4. We go on to the next slide. That is St. Mary's is our Grand Junction Hospital. And then we have 3 Montana sites. And if we go on to the next slide, you'll see some of our challenges. Here's our volume in terms of deliveries per year. When we are trying to create a one-size-fits-all, it's very obvious that one size isn't going to fit all, because we have 2 sites that are rural, and Holy Rosary is actually critical access. And we have just some real diversity in terms of what are our resources to help support these identified moms. And this just gives an overview. We're all baby friendly. We all want to do best care for our moms and our babies, right? So despite some of the diversity in location, we have that in common. We'll go ahead, and I did want to just talk about the tools we used from CPCQC. This was, hey, where are you at? This was just slightly over a year ago on the left. My chicken scratch there. You can see that 3 projects were not started, 4 were in planning, and 2 things we had in place. And within a year, this is all 8 hospitals now have 4 things in place, 1 in planning and 2 not started. So we made some great progress as a system. I think that we were able to really leverage some system-wide strengths, which was a benefit to working together. So we can go to the next slide, which talks about our initial EPDS tool used to screen for depression and anxiety was up and running. Lutheran and St. Joseph had been pilot hospitals for this program. And we recognized that through this work that we still had 3 hospitals that had not yet implemented EPDS. We needed a better way to track, and we needed to identify resources that were available once a positive EPDS score was received. And so by collecting that baseline data and leveraging the systems that we already had in place, the next slide shows what we were able to do with this data. So we were able to work with our clinical informatics partners and create a dashboard on our Epic system so that we could each track our own rates, look at prenatal positive for those who have SEL clinics. We could look at our delivery encounter percentage of completion, and then the number of positives. This was huge. So we could not rely on someone else to give us that data, but we get that now monthly in our Epic system. We also created a public shared, I shouldn't say public, but a shared landing site where we have a resource library of all the available opportunities for services. And then we created an SEL policy that is for universal screening of perinatal mood and anxiety disorders. And underneath that is also substance use disorder. And this gave us a cadence for how often to screen and what tools to use to screen. So that was great work. And then we'll move on to what were we able to do with substance use disorder specifically. We identified that we did not have a validated tool that we were using, and this was really exciting to do as a system. We were able to choose the tool that we were going to use and build it into Epic. And so that happened first quarter of this year. And based on implementation, we're able to see our rates of screening. So we have 100% screening. We have one site that does paper and then transcribes it into Epic, and the other ones are doing a verbal screen on admission. And then this was incorporated into that previous policy that I showed you and gives us our screening cadence. So if we go on, we can see what that looks like in Epic. It's under the social determinants of health, and a patient who identifies with a positive audit C+2 will show up on the top right-hand corner of the first screen as low risk, medium risk, or high risk. And then in the bottom, I did a screenshot of my own hospital, Lutheran, where I can see what was our percentage of completion. So last month, we completed 130 out of 150 patients. 5 of those were identified as high risk and 15 were not screened. So this gives me some really concrete education material to share with my staff. All right, and then this goes on to show, this is our data for the system, and you can see that the power of working together as 8 hospitals really gives us some powerful data. This is the number of patients delivered are on the top row. Number of patients screened is the next row. Number of patients who screened high risk. So these are the ones we should be identifying as connecting to resources, making sure they have a safe discharge plan. Also considering, is this a patient population to give naloxone to on discharge? And then the number of patients not screened. That bottom row gives us some education to provide to our nursing staff. Hey, we're not there yet. We have some more work to do. We need to continue to make this, the number of patients in the 4th row even smaller. And you can see also that St. Mary's in Grand Junction is our hospital doing paper screening, which I think is an interesting philosophy. Do patients give more of an honest answer when they fill out a paper screen versus a verbal screen, or is it in how the nurses are asking the questions? Is a combination of both, because their number is significantly higher for positive high-risk screens than the rest of our hospitals. So our team meets actually this week, and we'll give that some consideration. We can go on to the next screen. Is another thing that we did as a system. We created an order set that focuses on moms who are in labor and delivery and are actively withdrawing from opiates. This order set is available for all 8 hospitals, and it helps drive best care rather than reinventing the wheel or feeling like you need to reach out to the emergency room or internal medicine for some guidance. Our providers have made it very clear that they don't feel confident and competent caring for this patient population who's withdrawing. And so this order set helps guide their care. So this has been a huge win for our system. And the next slide goes into policies that we're creating as a system as well. So the first one on the left is acute withdrawal. It talks about some other processes that happen for this patient population, and it aligns with that order set. And then the policy on the right is, how do we manage post-op pain in this patient population? And so this policy gives us ideas. Gosh, should we do a tap lock for this patient or an on-cue pump? What can we do with their Suboxone if they're on that? Can we split their dosing or increase their dosing? And it gives all sorts of creative, helpful suggestions on how to help these patients who are struggling to manage their post-op pain. So those are 2 system policies that are almost finalized. And the next slide talks about our discharge follow-up resource link. So I mentioned that we had a place on our shared landing drive for mental health resources. And then we also have within that a specific list of resources for substance use disorder. And then you can see on the top left We have tabs built in for Denver Metro, Western Slope, Montana, and then telehealth. Because coming full circle and really thinking about those small rural hospitals that are in our system, they were really wanting something that was telehealth based, where we could link women in crisis to some resources that weren't available in those rural areas. And then last but not least, I'm gonna just tie it into one of our previous speakers. Lutheran is a pilot hospital for introducing or discharging patients who have been identified as at risk with naloxone. And we just had our first patient go home last week with her naloxone. We have decided to distribute it through our outpatient pharmacy so that this is a sustainable process. And we have a structure in place to make this a long-term project and goal. Super excited about this. We're currently in the midst of education with our staff on how to roll this out and educate patients on this topic. So where is our future work? Well, we definitely want to work on sustainment and keeping our stakeholders engaged. We've definitely had some turnover, even at the leadership level, just like everyone else. And so that's been a little bit of a moving target, but we want to keep that going. And we want to also pull in our providers who don't always feel confident actually prescribing Suboxone. And so that's one of our next steps. We want to continue to identify resources for both our urban and rural areas and make sure that we have a follow-up plan in place for our high-risk patients. So that's what we'll be working on. And I thank Colleen for inviting me to share. It's been a journey working as a system, and it's been exciting because I think we've made some great work together as a team. I'm going to hand it over to Michelle.
Hi, thank you. Can you guys hear me?
Yes, we can.
All right, fabulous. So thank you, Colleen, for the great introduction. And I have really had the pleasure and opportunity to develop this program over the last 6 years now and dip my toes kind of into a lot of different things. We can go to the next slide. Our program really is about helping moms and babies achieve and maintain freedom from addiction. And how we've been able to do that, we can jump to the next slide. We started with a really, really small systems grant in 2016. And I took an opportunity to jump from labor and delivery into doing this. And since then, Signal Behavioral Health has picked up our funding, and they've been extremely generous and kind of letting us do lots of different things with this program. Really, the bulk of this program is a nurse home visit model. So we are able to work with our moms from pregnancy throughout that first year postpartum. And we really do everything from kind of that case management piece. So connecting them to resources, anything from OB care to substance use treatment to housing. And in that prenatal part of their lives, we can also do childbirth prep. We really focus on preparing them for delivery and really having them know an understanding of pain management options, kind of keywords they can take to their OB provider to make sure they know all their options, especially our patients who are on that therapy. I love that we've had CHoSEN come in a little bit after, about 2 years after we started this program, and the work that we're doing with the AIM Collaborative, it's really supported our work here and enabled us to kind of expand our education and knowledge. So we do a lot of the Eat, Sleep, Console and NAS education for our moms. And then following delivery, we just continue to work on, supporting recovery. It's that really great relationship and rapport we try and build with our moms in doing those home visits and seeing them frequently and being available to them when they need. We do child development assessments really regularly to try and, if we see any identified gaps that we can refer them to early intervention, or at least have them reach out to their pediatrician. And we also have the opportunity, we run a Circle of Parents support group that we're able to do weekly, and we have 10 to 20 moms or more that join weekly, so that's really great. I'll pop back to that. And this program has really been able to work on several different projects, a lot of which Amy just told you all about, and that's been really rewarding, and just kind of, I think, helps expand on our name of the program, which is Recovery Nurse Advocate Program, really being an advocate for these patients and the work in the community to help support them. We can jump to the next slide. I think Amy actually covered these beautifully in a lot of these in her talk. I was able to dabble a little bit when the SEND provider education work group started, been able to be part of the CHoSEN collaborative here at Lutheran, and really working with our teams here to provide that education and support to our patients as well as our staff. The AIM collaborative to just standardize screening and support for the system. And yeah, we just rolled out our Narcan distribution and got to do that with our first patient, which was great, as well as the policy changes that Amy talked to you guys about. You can jump to the next slide. So when I say we, our team consists, there's 2 RNs, myself and Lindsay. We have 3 doulas, and they have been just really instrumental in helping maintain and support our patients, both prenatally, at delivery, and after delivery. Each of them has kind of a great subset of tools themselves. One has worked as an addiction counselor in addiction medicine for a very long time, specific to this population. Another one does a ton of work with another organization to support women. They've done some things at the state level. And then our 3rd doula has a ton of experience with domestic violence. So the 3 of them have been really instrumental in supporting our patients beyond what Lindsay and I can do. We're really looking to add more doulas and really working to add a peer coach. And like I said, our evidence-based support group is really instrumental, and patients don't have to be part of our program to join that support group. It is open to the community. So that's been really great for our moms. Jump to that next slide. And just, families we've served, the really great thing about this program is our patients don't have to deliver at Lutheran, and they don't have to have had delivered at Lutheran for us to engage with them. We really, right now, we have patients as far north as Longmont and as far south as Castle Rock. And we have about a 40% referral to engagement rate, which I think is maybe fairly standard for a home visitation model. Our support group really sees about 10 to 15 parents weekly. And we just really engage. We have a lot of partnering agencies, our OB practices. We get some referrals from the Jefferson County Female Offender Program, work really collaboratively with the Aspen Center, starting to really partner with Jefferson County Human Services and other human service agencies around the Denver area. And recently just started partnering with Jefferson County's Nikita Home Program. They're just seeing a lot more referrals for not only babies who were born prematurely, but that were substance exposed. And so we're really partnering together to give those families the kind of the biggest range of services and support that we can.
Great, thank you so much to both of you. Just really amazing work. I don't know how you have the bandwidth to do what you do. When you said, Michelle, that you had a team, I was thinking, 10, 15, you're like, I have 2 nurses. that is really incredible. So let's open it up for some questions and discussion. Please feel free to unmute yourself or chat in. All right, I can get us started. This was touched upon earlier in the day, where there's some concern, and this is somewhat of a cliche of a question nowadays. It's, why screen if we don't even have resources to then deal with the problem that's been identified? And so just wondering, what that experience has been like for both of you, both screening for maternal mental health conditions as well as for substance use, for that group of women that do screen positive, if in fact resources were readily available for them, in a timely fashion.
I think that we've been privileged to have some really great social workers in our system who actually do go visit all of these patients and connect them with resources, which has been significantly helpful. And then St. Joseph has created a program called the Bloom program, where they have a dedicated staff. I guess I'm not sure how many there are right now, but I believe they have 3 social workers who have a full schedule available to see moms who are struggling, identified as at risk. And so that program was developed out of a grant and is now sustainable through SEL.
It's
I
amazing.
think we're working on getting more resources just because the need is so high. I don't know, Michelle, if you have anything else to add.
Yeah, no, I think Bloom has done an amazing job with that maternal mental health piece, and they are looking to expand their services as well as, like Amy said, make it sustainable, and really opening up outside of our system. And we're really looking at, we've talked a lot about those warm handoffs and making it easier for patients. So we're really looking at partnering and kind of trying to make more of a central navigation referral process so that we know those referrals are being made and if they're being responded to. So we're adding on to that.
Other questions? Both of you are really what I consider sort of boots on the ground. You are there and you have your finger on the pulse around, what's really happening at your health facilities and sort of at individual levels. And you both have been doing this work for several years. And I was wondering if you could give us a sense of sort of changes that you've noticed either in your client experiences, what your clients are going through in terms of substance access to treatment. What is different now in terms of trends that you're seeing in your patient population than when you first started, and what should we be aware of?
Gosh, I think women are slowly seeing that there are lots of supportive services out there. I'm hearing that when I meet new women who maybe delivered at the beginning of this program or at the beginning of the CHoSEN work that said, I wish something like this would have been available when I had my last baby. I'm seeing some moms that I saw before that may still be struggling with substance use, but know that these are available and are able to reach out. I'm also seeing moms who I saw that were using in another pregnancy, but reached out again for just general support that have been sober. So I think those are really great changes. I think a shift in decrease in judgment and stigma at the caregiver level, especially recognizing the statistics in Colorado that accidental overdose is really the #1 reason for death in our maternal population. And although some, like Amy said, still aren't super comfortable with some parts of it, they're really starting to open up to change and a little more open to having those conversations and just talking to their patients about it, which has been really great. And then I think support at different systems levels to support this work and support these patients. I think the program director from Aspen Center has just a great phrase, which is something along the lines of, these are the children of the women that we didn't help before, the last generation when we didn't have these things. So this is really now our opportunity to hit 2 generations and kind of hopefully decrease this in the next generation.
Yeah, that is really beautiful, sort of intergenerational work that's being done.
I love that. I never in a million years, when I graduated 30 years ago from a Baptist college in Minnesota, thought I would be leading education around naloxone distribution. But I feel like that's what we owe our families and we need to do it. It's the right work. And I think the fentanyl crisis was something Michelle didn't mention, but we're certainly seeing a lot more of that here at our suburban hospital and seeing a definite effect on our babies for long-term withdrawal.
Well, thank you so much to both of you. We appreciate your time and your expertise.